Good morning. Greetings from Prasad Institute of Medical Sciences. I am Dr. GK Singh, the founder director of AIMS Patna. Recently, an advocate friend of mine, Dr. Neeraj Gupta, who is a graduate from AIMS Delhi and who I keep advising on cases for and against doctors for medical negligence, approached me for a very interesting case. In this case, a 71-year-old patient approached a corporate hospital with a raised prostate specific antigen level. Now, this is indicative of carcinoma prostate. The pathologist's wife of the doctor confirmed the carcinoma prostate by a needle biopsy, and prostatectomy was done using the Da Vinci robotic system. Patient has diabetes, developed urinary tract infection, and succumbed to hepatorenal failure. The relatives saw the YouTube, which I am going to show you, and following the death have filed a rupees 30 crore compensation case on the surgeon, the pathologist, wife, and since the surgeon owns the hospital having the Da Vinci system, the hospital too. We are representing the hospital in this case, and let's see what we can do.
The death rate from prostate cancer in the first 5 years is practically 0%. Therefore, any treatment rendered is difficult to discern until you look at it decades later. The studies that have pointed at that have illuminated this detail. I don't think we should be treating prostate cancer with radiation, prostatectomy, or any other intervention. Early stage prostate cancer should be treated without biopsy, should be supported without surgery. Well, how the heck do you know if you have prostate cancer? I'm going to tell you why you should never get your prostate gland biopsied. That's a bold statement, but I'm going to back it up. This, of course, is my medical opinion based upon my research, clinical experience, and abundance of evidence. Never stick a needle in a prostate gland. Well then, you may wonder, how in the world are you going to diagnose prostate cancer? And how do you know if it's aggressive or not? You have to appreciate the fact that prostate cancer treatment has evolved based upon presumption of benefit, rational thought, but without evidence of actual good outcomes. It was in the late 1800s when the prostate gland was first removed in modern times. A surgeon in England declared it to be a rare disease. How do we get from there to where we are now? You realize, of course, that the death rate from prostate cancer, well, you don't realize, so I'll tell you, it's actually been going down year over year for the past 20 years or so. And yet the rate of newly diagnosed cases, according to the current criteria, goes up. That's a paradox. Why would death go down but diagnosis go up? The reason is that we're making a false diagnosis on a non-cancerous condition in the prostate gland. In fact, it's normal for the prostate gland to develop atypical cells. These cells get mistakenly labeled as cancerous by overzealous pathological interpretation. It's a fact that in studies looking at men who die for other causes past the age of 90, the overwhelming majority of them have cancer cells within the prostate gland, even though they die of something else. Upwards of 80% in some studies. Well, if 80% of the population acquires a certain cell type, couldn't we call that normal or inevitable? Now, if you're inevitably going to get, you got to connect the dots here, folks. This gets a little bit complicated. If you're inevitably going to develop cells in the prostate gland that are labeled cancerous, and if the PSA level, the prostate-specific antigen, always goes up over time, you've got a conundrum. Because the trigger for biopsying the prostate, in many cases, is an elevation of PSA. Guy feels totally fine, goes to see the doctor, they do a blood test. Oh, your PSA went up from 2 to 5. we need to do a biopsy. Stop the presses. Do not do the biopsy. Nothing good comes of it.
When you lie down to sleep, your muscles relax, and in many people, that includes the lower jaw. It shifts backward, and
now before any test should be performed, a question needs to be asked. What are you going to do with the result? And how will it make a difference and improve my health? So let's start answering that question. It turns out an important study, 2 of them actually, came with a similar conclusion, looking at men with early stage curable prostate cancer. Half of them had the gland removed, the other half did nothing. I mean, literally nothing. They tracked them over about 20 years, and you know what they found? That the death rate was the same in both groups. Not only was it the same in both groups, those who had the gland out and those who didn't, but the death rate from metastatic prostate cancer was the same. Oh, wait a minute. You mean you had the gland removed, you suffered the misery of surgery. I don't care how great they tell you they are at clipping out your prostate. I don't care if the Da Vinci robot can come in at a zillion angles. You're sacrificing bladder control. You're sacrificing sexual vitality. You're exposing yourself to infection, to pain, to complications. Yeah, some people die post-operatively. Yeah, blood clots can happen. Heart attacks can happen. And for what? No gain. I'm sorry to inform, no gain. All right, so taking out the gland, how about x-ray? How about radiation therapy? How about pellet implants? How about none of them have been shown to actually work? The reason is that you've got to wait 20 years. The death rate from prostate cancer in the first 5 years is practically 0%. Therefore, any treatment rendered is difficult to discern until you look at it decades later. The studies that have pointed at that have illuminated this detail. I don't think we should be treating prostate cancer with radiation, prostatectomy, or any other intervention. Early stage prostate cancer should be treated without biopsy, should be supported without surgery. Well, how the heck do you know if you have prostate cancer? If you don't biopsy it, you don't know. The point is, there's enough means of assessing it that you can make a reasonable judgment. That is, the PSA rises. Do not stick a needle in it. Among the bad things that happen, there's futility of treatment at the end of the rainbow. Sticking, and these are not needles, by the way. These are like core, like trocars that are plunged into the prostate gland, causing bleeding and pain. You bleed the lesion, you stick a needle in it, you pierce the seal. Now, many surgeons and doctors, they would like to convince you that there's no risk of metastatic spread by sticking a needle. Come on, folks. Use common sense. You stick a needle in a tumor and it bleeds. That ain't good. In fact, there are studies. These studies were done on women with breast cancer. And what they found in this study, and it is informative regarding needle biopsies in general. 2 groups of women with very suspicious looking mammogram results, likely cancer. One group went directly to a lumpectomy without a biopsy, took it out. The other group had a biopsy first, followed by a lumpectomy. The folks with the biopsy had a much higher rate of metastatic disease subsequently. All right, that's interesting. Another study where they did needle biopsies and then the women subsequently had a mastectomy or a lumpectomy. They analyzed the tissue, and you know what they found? They found several of them, significant numbers of them, had cancer cells along the needle track. So there is clear evidence that this can happen. Stop denying it as a risk factor. The prostate gland works to contain abnormal cells. This is what the body does. If you get an infection, it tries to wall it off. If you get cancer, it tries to wall it off. Don't screw with it. So you stick a needle in, you can spread the cancer. You stick a needle in, it'll lead to what? There's an approach to men with elevated PSA. It's called conservative monitoring, watchful waiting.
बहुत सारे लोग समझते हैं कि 4 दिन में हम हिप्नोसिस सीख ही नहीं सकते और मैं आप सबको बताता हूं कि आप 4 दिन में हिप्नोसिस प्रो
Active surveillance, it has these different names. It means we're going to biopsy you, Dr. Pederuti, we're going to stick a needle in your prostate every 6 months just to see what's happening. You cannot predict what comes next based upon the result of a needle biopsy in the moment. That is fiction. That is speculative hope. I'm going to biopsy your prostate, and I will be able to then determine whether we should remove it. We already decided, we've already concluded, we already have evidence that taking the gland out causes harm. Here's the big problem, though, psychological and practical. So now we've got this elevated PSA. Now perhaps a biopsy is done, and we have a diagnosis of early stage cancer or suspicious looking cells. Where do we go from there? The doctors would say, well, we can take out the gland or we can do nothing. Folks, that's psychologically untenable. And it is impractical, and it is not consistent with what we know about the biology of Homo sapiens.
Well, a very powerful advice, most likely to succeed in convincing the court. How do we counter it? We searched the medical literature and came out with the following piece of evidence. Let us examine it together. So let us introduce you to this calculator where you can feed your own comparisons between two types of treatment, the events that can occur if that is happening, the positive possibilities and the negative possibilities, what is the probability of each, what is the value, the negative or the positive value that the patient ascribes to that outcome, and then you multiply probability, that means expectation of the outcome, with the negative or positive value, so you get expected value of that particular outcome. You add the expected value and get a sum of the expected values. Now the sum of the expected value tells as to if it is positive. So if the number is as much positive, so that is as much preferred by the patient. So here we have placed masterly inactivity and we are comparing it with aggressive treatment of carcinoma prostate. The positive possibilities are will die from other causes. 202 out of 250 patients died of other causes having carcinoma prostate, and therefore that probability comes out to be about 90%. 90% chance that you will not die from prostate cancer. And the patients really value this high. In a scale of plus 100 to minus 100, they ascribe 70 value to this particular outcome. Then prostate will remain asymptomatic. The probability is slightly low, but the value ascribed by the patient to this outcome is very, very high. Then the negative possibilities in masterly inactivity will die from prostate cancer 10%. 1 minus the probability of not dying from it. Will have paraplegia, very, very remote chance, but a very high negative value because you become disabled. Will have bone pains, far more chances, but far less problem. Will have bone fractures, still less chances, and but much bigger problem. So this is the value and this is the probability of these outcomes. Now the cost of masterly inactivity is, let us say, minus 5,000. Over 20 years, it can be more, but because the life is nearly normal, it is just observation. Let us keep a value of minus 5,000. So you multiply the probability with the value and value ascribed to that outcome, and you get an expected utility. Probability into value, expected utility of that, and you combine all the expected utilities plus and minus and get a expected value total for that particular outcome. Now then you repeat the same exercise for the aggressive treatment outcome, and when you do that, you see that this is about 10 times less positive as compared to masterly inactivity. So the masterly inactivity wins, the aggressive treatment loses. Similarly, our next question was MRI versus core biopsy, and again we find that the sensitivity of MRI, high sensitivity and high specificity, are important values. So sensitivity means that you will not miss a diagnosis of prostate cancer, and specificity means that you will not make a false diagnosis of prostatic cancer, because that is very psychologically traumatizing. So sensitivity of MRI is 80% and specificity is 90%, but the advantage is that it is not invasive and it can be graded. It can give you a grade, 0 to 6 grade, and you can keep on observing the grade as the problem progresses, and finally you will be able to monitor the patient because of this. So monitoring becomes possible because in the MRI, but you can't keep on doing a repeated biopsy because that is not acceptable. So it's far more easily monitorable MRI. So 70-90 value ascribed to sensitivity and specificity can be graded 70 value, very good, and not invasive 70 value. All these are positive. Cost minus 5,000. So that's how we grade MRI. Then we go on to grade core biopsy. Sensitivity and specificity. Sensitivity is low, is 0.32. But therefore, this has to be graded a little bit less. Let us say we'll grade it 50. Okay. Then specificity in making a false diagnosis, very, very low. So very high specificity, 0.90. If it is positive, then there is prostatic cancer. But you have to understand that this specificity makes you diagnose 80% of the people, elderly people with prostatic cancer, and ascribe aggressive treatment to them when nothing should have been done. So this cannot be graded. So let's put here cannot be graded. So that's a negative point. And therefore, let us ascribe a negative value to it, say minus 20. Then the cost is far more, minus 15,000, and chances of infection, bleeding, spread, we have recorded the chances, and we have recorded what the patients are likely to ascribe to these events. What is the utility that the patients are likely to ascribe to these events? So here we find that when we add the expected utilities for MRI, it is a far more positive number as compared to those the number that we ascribe to core biopsy. So this given, so very difficult to support the hospital, not only on the basis of argument, but also on basis of numbers. What should be the advice then? Settle out of court, or bad advices can be linger the case or bribe the judge. Click on the shareable link to download the calculator Excel file. This file you cannot edit, so you make a copy of it and then use the copy to fill the probabilities and the values that your specific patients assign to get to a decision regarding investigation or treatment.